Good afternoon, ladies and gentlemen, and thank you for waiting. All lines have been placed on listen-only mode, and the floor will be open for your questions and comments following the presentation. Without further ado, it is my pleasure to turn the floor over to your host, Mr. David Hall. Mr. Hall, the floor is yours.
Good afternoon, and thank you, Wes, for that nice introduction. And again, welcome. As Wes mentioned, I'm David Hall, and on behalf of VHQC, the Maryland Patient Safety Center, and the Maryland Hospital Association, I would like to welcome you to our kickoff event for stopping sepsis and long-term care. First, just a few housekeeping details. First, this webinar will be recorded, and a transcript will be available. You'll get an email when it's available on our website. Also, during the webinar, we will have a chat function enabled. Feel free to type your comments and questions. We will be monitoring the chat room and will answer your questions during the webinar if possible. If not, we'll address them at the end during the Q&A session. Also, throughout the webinar, we will ask a few questions in the polling feature. Each question will take about 30 seconds to complete, so there will be a pause during that time. At the end of the polling, we ask that you exile the questions, which will return you to the chat function. And finally, we would greatly appreciate your feedback to assist us in future planning. Please take a few minutes at the end of the webinar to answer the evaluations. It will be on the right-hand side of your screen at the end of the hour. I've introduced myself to you. At this time, I'd like to introduce you to the rest of our team members for the Stopping Sepsis and Long-Term Care Project. In a few minutes, you'll hear more about each organization, and you will hear how this project fits into the mission and goals of each one. In addition to myself from VHQC, we have Sheila McLean, who is our VHQC Program Director for Maryland. From the Maryland Patient Safety Center, we have Bonnie DiPedro, and from the Maryland Hospital Association, we have Justin D'Ambra. And again, we're very pleased to be working with these organizations and look forward to our continued engagement with them on the Stopping Sepsis and Long-Term Care Project. Things to think about as we get started today. During today's webinar, I encourage you to commit to being attentive and engaged, open, collaborative, and actionable. I know from my own webinar experiences, sometimes in our busy lives, it's easy to get distracted and want to answer some emails or check a message on your cell phone, but at this time we just ask that maybe you exile your emails, put your cell phone on silent, and be open and engaged with us for about the next hour. As I mentioned throughout the webinar, we will ask a few polling questions. We'd like for you to participate so we can learn more about you and your needs, and you can learn more about others in the network. Today's agenda will provide an overview of VHQC, the Maryland Patient Safety Center, and the Maryland Hospital Association. During this kickoff event, we'll also review the goals of the Stopping Sepsis and Long-Term Care Project. We'll look at and understand some of the components of the project. We'll get started with understanding quality improvement or the nursing home world, QAPI, and we'll discuss next steps in stopping sepsis. A little more about VHQC. VHQC is a private nonprofit healthcare consulting firm that has served as the QIO for Virginia since 1984. We now serve as the QIO and QIM for Maryland and Virginia. We are made up of experienced team members and consultants. Our team members come from a wide healthcare background. We have former hospital executives, nursing home administrators, physician practice managers, nurses, health IT managers, health communicators, physicians, and pharmacists on our team. We invite you to view our website to learn more about VHQC. And now I'll turn it over to Justin D'Ambra from the Maryland Hospital Association, who will provide an overview of the MHA. Welcome, Justin, and the floor is yours.
Thank you, David. As David just said, I'm with the Maryland Hospital Association, and we represent all acute care hospitals in Maryland. We're really glad to be partnering on this collaborative. Bonnie's going to detail the ongoing hospital-side collaborative here in a second, but with my very brief time, I just wanted to touch on the framework Maryland hospitals are operating under to help provide some context for our involvement. As many of you may already know, Maryland hospitals are part of a unique waiver demonstration, and this demonstration mandates quality targets such as readmissions reductions and some financial targets as well, that the state hospitals have to collectively meet. Additionally, there are several non-demonstration quality targets that our hospitals have to reach as part of our annual payment policy on things like mortality reductions. And so another layer in this is that our hospitals now receive revenue under global budgets. So the net effect of these structures is that Maryland hospitals are really on the hook for bending the cost curve and improving quality across entire episodes of care. And the responsibility is expanded greatly to elements beyond what occurs just within the walls of their facilities. As a consequence, their partnerships with organizations you represent become very important, and working cooperatively to improve quality is key. So I just want to say thank you for being part of this, and I look forward to being on the team. David, back to you.
Thank you, Justin. And now Bonnie DePietro from the Maryland Patient Safety Center will tell us about their work. Bonnie, the floor is yours.
Thank you. So the Maryland Patient Safety Center, in partnership with the Maryland Hospital Association, has been working on a hospital collaborative on improving sepsis survival. We have two cohorts. The first cohort began in July of 2014 and kicked off with 10 hospitals in that cohort. Interesting, we did limit the number of participants in each cohort to 10 in the beginning, just because there's some intensive work going on and intensive consulting, especially on team engagement and human factors. So that's why we limited the number of hospitals that could participate. The second cohort began in April of 2015, and we did expand to 11 hospitals. So we have a total of 21 hospitals that are working with sepsis teams within their organizations to improve survival of sepsis. In that collaborative, it required team attendance at some 2 face-to-face meetings, attendance on monthly calls that eventually go to every other month, and webinars. And then they had to submit to us their hospital plan, their sepsis mortality rates monthly. They have to do a quarterly status report just telling us where their team is and some of the data that they're collecting. And what also is different about this particular collaborative is we are interested in their outcomes. We know that process metrics help to improve quality in the organizations, and we do expect them to be looking at some of their process metrics, how fast they're getting blood cultures done and antibiotics in and started, those things, for example. But we are only collecting their mortality rates, and then we're comparing that with the intent of having an impact on the overall state mortality rate. 21 of those hospitals, like I said, are working on this, and they're very interested in working with you on the patients that you send to them. We know that most of the sepsis patients come in through the ED, and so they are very much interested in partnering with the long-term care community that admits to their EDs. We do have some of those participant teams on the call today listening in, and we're hoping to help facilitate a nice partnership between our 21 hospitals that are participating in our collaborative and those of you that are going to be participating in this project. Thank you, David.
Thank you, Bonnie, for that good overview. On this slide, we have a list of those 21 hospitals that Bonnie mentioned in their sepsis collaborative. Again, as she mentioned, part of our audience today consists of representatives from those hospitals. Again, we welcome you folks and hope you come away with a better understanding of the project and can expand your current opportunities and see working relationships with the local long-term care facilities growing. On the next slide is a list of nursing homes working on this project. One of the goals was to recruit nursing homes in the market area of the 21 hospitals working on the acute care side of the project. And as you know, we feel that if we've achieved this, many of you on the phone today may recognize hospitals and nursing homes that you work with on a daily basis. And again, we hope this project will provide a forum for you to work more closely together going forward. Now that you've heard about this, at this time we'd like to do our first polling question. So now for a few selected questions, and the question is, what role best describes yourself and those in the room with you? In a minute you'll see the question pop up on the right-hand side of your screen. We ask that you click all that apply and then hit the submit button in the lower right-hand corner. And again, it'll take a few seconds for that to populate, and we can see some of the results. As you take time to complete that, we'll just move forward with the project today, and we'll go back to those results in a few minutes. Again, I can see it's populating now. Again, we have several administrators and DONs and QAPI professionals. If you answered other, if you'd like to drop in the chat in a few minutes and tell us what that is, looks like we have a good mix of caregivers and those on with us today. So again, thank you for participating in that polling question. So you might ask, why sepsis? Why is this such an important topic, and why is it getting so much attention from payers, regulators, and providers? This slide highlights the most important fact. It's about saving lives. Sepsis is the leading cause of hospital admissions from U.S. nursing homes. More than 1 million Americans are diagnosed with sepsis annually, and up to 50% of those patients will die. Nursing home providers and staff can play a critical role in preventing and treating sepsis. Again, this initiative will link you with hospitals participating in the Improving Sepsis Survival Collaborative led by the Maryland Patient Safety Center, and will assist us in working together going forward. Let's take a moment and review the goals of the Stopping Sepsis and Long-Term Care campaign. We want to provide education and resources to help licensed staff and nursing assistants more rapidly recognize the signs of infections. We want to reduce mortality rates, hospitalizations, and healthcare costs by treating residents for infections before they become septic. We want to implement infection prevention strategies such as hand hygiene and antibiotic stewardship to reduce infections that can lead to sepsis. Again, we want to engage families and caregivers who can help monitor for the early signs of infection. We'll take a look a little more closely at goal number 2. You will note that we hope to decrease the hospital admission rate for sepsis, and we hope to also decrease the mortality rate of those who are admitted. Our primary data source will be Part A claims data and through some self-reporting from the nursing homes. I think most of you on the phone do a good job of recognizing sepsis. However, we want to emphasize, while the goal is to decrease sepsis admissions, we may actually see a bump in admissions as we roll out the program. As we meet the goal of earlier recognition, admissions may go up and hopefully mortality will go down. But we always want to emphasize that we want to admit people when it's indicated. In year 2 of the project, we'd like to see the nursing homes participating to each one of these 3 measures noted on this slide and use it as a quality improvement project. These measures focus in on assessments and reactions to changes in residents' condition. Again, you can see it relates to admission assessments, a timely assessment with a change of condition, and some timely monitoring of lab tests that are related to sepsis diagnosis. So you might ask, how much of my time is this project going to take? Maybe the question should be, how much time and energy can we save by leveraging our QAPI activities? And how can we help you realize a return on your investment by being in our network? By aligning our efforts, we can be effective and efficient in reaching our goals without adding to your burden. As you'll see, these efforts align with your own organizational quality goals. They align with VHQC Nursing and Home Improvement Network. They align with the goals outlined in QA and PI. They align with the Joint Commission CMS Hospital Sepsis Core Measures, the Advancing Excellence Campaign. Again, they align with the Maryland Patient Center Sepsis Collaborative, and they align with HHS payment reform, which we'll go into a little detail in a few minutes. At this time, we'd like to do our next polling question. Jennifer, if you post the question, and again, the question is, in addition to sepsis, what are your infection-related opportunities for improvement at your nursing home? Again, I'll take a few minutes for it to populate, but we'll keep going at this point. Again, thank you for your answers. This will help us in future planning. And again, if you chose other, feel free to drop down to the chat function and put that in the chat box. Again, we see that pretty much across the board, hand hygiene, avoidable hospitalization, CDF, there seems to be a lot of answers for what we have listed there, and that will help us with our future planning. So again, thank you for those answers. So the big question is now, how can we affect change and make improvements within the sepsis reduction efforts? On the next few slides, we will review the time frame for the project and some of the specific components and go into a little detail about each. First, let's take a look at the timeline. As you noted, this is a 2-year project from October 2015 to October 2017. You might ask what's been happening since October of 2015. You'll note that the first bullet is related to recruitment. The 3 sponsoring organizations that you heard from have been working hard behind the scenes to review data and reach out and recruit you folks on the phone today. And again, we thank you for being part of this project. Some of the key dates of the project are recruited by the end of December. This webinar today shows that we met our goal of having a kickoff project before January 31st. And by the end of February, you will receive a baseline data package from us and some long-term care sepsis screening tools. Our next webinar in February will be devoted to data and the screening tools, and you will gain an understanding of these at that time. We hope that by the end of March that you may have some of these tools implemented in the nursing homes, and also by the end of March, we'll have some opportunities for some focused dialogues between the hospitals and nursing homes. By the end of June, our goal is to assist you in reviewing your facility-related infection policies and procedures and offer assistance to you in areas that you might need some help. And the last bullet, by the end of October, we hope to be offering you ongoing assistance through the end of the project on PDSA cycles, giving you additional data and showing some correlation that we've made improvements with the project. Specifically, some of the components of stopping sepsis, again, we're going to use a collaborative approach and improvement resources with proven effectiveness. And we'll look at these on the next few slides. First, the collaborative approach. We're going to use educational webinars and workshops like we're doing today. We plan to offer regular webinars, conference calls, office hour calls, and roundtable meetings. Much of this work will be in a virtual environment like we're doing today, so we want to emphasize the second bullet of our 24/7 online community. This website offers a repository of resources. It'll have recordings of webinars, access to many tools, form links, and web links to support the project. Most of you should have received instructions regarding how to gain access to this site. If you need additional information, please contact me, and we'll provide you with the necessary assistance. Here's a screenshot of the Quality Innovation Network online community. Again, this provides a 347 location to engage with other nursing homes in the Stopping Sepsis project, to engage with VHQC consultants and expert faculty. If you've not done so, we encourage you to join today. Improvement resources with proven effectiveness. The Minnesota Hospital Association has developed a sepsis toolkit for long-term care facilities as part of a sepsis collaborative in their state, and we are very grateful they've given us permission to use this in our work. You will see an example of one of these tools on the next slide, and you'll be introduced to all the tools during our next webinar in February. These tools will play a critical role in assisting your staff to recognize sepsis in its early stages and guide them to take appropriate action. As we move forward with the project, again through our online community, you will have access to forums, the tools, help guides, and other QAPI and PDSA resources. And you also have consultant support by email and telephone. Again, this is an example of one of the tools from the Minnesota Hospital Association. They're based on the simple principle of seeing sepsis 100. The warning signs, if you have a resident with a pulse that's greater than 100, blood pressure that's less than 100, and temperature that's greater than 100, and a change in usual condition, these are all warning signs of infection and should initiate additional assessments from licensed staff. Again, the February webinar will introduce you to all the tools available from the Minnesota project, and there are many more to accompany this as you see on your screen. So why are we changing our methods of making improvements and measuring quality, and what's all this talk about QAPI and PDSA? To give you some background, as you may be aware, as part of the Affordable Care Act, CMS is now reinforcing the critical importance of how facilities establish and maintain accountability for quality assurance and performance improvement. Facilities are required to have an acceptable QAPI plan within a year of the rule becoming effective. At this time, the rule is still pending, but the process has been vetted and a date to be forthcoming at any time that the rule will go into effect. You can see on the screen that there are many other federally certified programs that have been participating in QAPI for many years. I'm sure that our colleagues on the phone today from the hospitals are well versed in the QAPI or continuous quality improvement process that's been in place in the QA and the acute care facilities for over 20 years now. The model improvements that you see on the screen will provide what we will roll out and will provide assistance for with this project. And this model is the PDSA model. It consists of two parts. The first part is the thinking or setting your aim. And the second part is the doing or testing part. The thinking part consists of three fundamental questions, and we'll look at those in just a second. But as we often face many challenges in healthcare, we often want to jump straight to what we think is the solution rather than working through the root of the problem. If you answer the three fundamental questions you see at the top of your screen, it will help you with dealing with the issue that needs to be addressed. And let's review those first three questions. Again, first, what are we trying to accomplish? This is where we formulate our problem to an aim statement. For example, as with this project, we want to decrease the number of infections within our facility. Next, how do we know that change is an improvement? Because not all change is an improvement. At this point, we want to set some measures. For example, we will reduce the number of facility-acquired infections on the skilled rehab unit from 10 to 5 over the next 30 days. We want to make sure our goals are specific, measurable, achievable, relevant, and time-bound. And the third question the answer is, what changes can we make that will result in improvement? Obvious changes may come from those who work within your system, from brainstorming, or from the experience of others. Again, an example may be within 30 minutes of a change in condition, a resident will receive an assessment by a licensed nurse. And then next we'll move into the PDSA cycle. We recognize there's a learning curve associated with this project. On this slide, there are many resources available to you through the CMS website. Links to this site will also be on our online community. Again, the QAPI at a glance provides resources to how to implement QAPI, the 5 elements of QAPI, how to do a PDSA cycle, how to do a root cause analysis, and many other resources. So again, there are many tools to help you as you begin this process. The new CMS provision expands the level and scope of required QAPI activities to ensure facilities identify and correct deficiencies and sustain performance improvement. QAPI is a data-driven, proactive approach to quality improvement. It involves all your members of your organization to continuously identify opportunities for improvement. It addresses gaps in systems through planned interventions. And QAPI adds performance to your existing QAA process. It serves as a foundation for improvement, and it supports person-centered care by developing systems and processes to engage families and residents. Let's take a look at this model for improvement in QAPI in action. Let's take a few minutes and review a very simplified overview of how we see this process going forward. And we're going to look at a fictional story of the ABC Nursing Care Center. This is a scenario you may see or you may have experienced it already. A hospital official calls you, the local administrator of a skilled nursing facility. He asks if you want to be a preferred provider in his network, but they are concerned with some new regulations that penalize hospitals for admissions. It's been noted that sepsis is the leading cause of hospital admissions from long-term care providers. The hospital facility asks you if your facility has had any plans to decrease the sepsis admission rate, and he asks if you have a program to review your admissions or readmissions to determine which are potentially preventable. After the call, you review a recent newsletter that you also received regarding HHS payment reform. You retrieve it and you note that Medicare is moving from a volume to a value based in payments. And the payment models are going to be tied to how well providers care for their patients instead of how much care they provide. And the goal has been established that 90% of the fee-for-service payments will be tied to quality and value by 2018. Reading further, you note that hospitals with high admission rates are financially penalized. Accountable care organizations and bundled payment models can only be financially viable by reducing readmit rates greater than 90 days. You note that a major focus of Medicare Advantage plans is finding ways to reduce hospitalization rates, including readmits. And we see that there's a skilled nursing facility value-based purchasing statute that requires CMS to implement the 2% withhold of Part A payments that can be returned based on your hospitalization rate. And you note that starting this year, that public reporting 5-star will add rehospitalization rates to their reports. And you see right off the press, you know, the CMS memo dated December 23, 2015 to state survey agency directors. And this memo goes into detail regarding a 3-year pilot project starting this year to improve the assessment of infection control and prevention regulations. The project outcome will be new surveyor tools and survey processes that can be used to optimize assessment of new infection control regulations that are forthcoming. So you call a meeting of your senior staff, you review the newsletter, the CMS memo, and the hospital's request, and you decide to try this new PDSA model and start a sepsis project. After discussing with your team, you learn there's an acute care sepsis collaborative in your state, and you also learn that the QIA and QIO that just started a long-term care sepsis project. The QIO gets you the information noted on the slide. You note that your facility has a higher rate of admissions due to sepsis than the state average, and a higher rate than other facilities are in the long-term care sepsis project. You see this as an opportunity for improvement in your facility. So you retrieve a PDSA worksheet and meet with your team to discuss the project. After discussion, you write your aim statement. And again, the page that you see on the screen now represents the P in the PDSA cycle. So after discussion, you write your aim statement, which would be, you want to implement a sepsis reduction program, which will lead to a decreased rate of sepsis admissions and readmissions to the hospital, and will in turn lead to a reduction of facility-acquired infections. The goal is to see a 50% reduction in sepsis cases that have to be transferred and admitted to a local hospital. The baseline data is based on calendar year 2014, and the reduction goal will be achieved by December 31st, 2016. And next, you describe your first test of change. And you say you're going to use the Sepsis 100 toolkit will be introduced to your facility, and all staff will be trained in the effective implementation of the tools. And again, the person responsible and your timeline and where your this education will take place is on the form. Next, you outline your plan. You're going to obtain and train staff with the STEAM sepsis tools. You're going to distribute the tools and appropriate posters to your units. You're going to instruct the staff to use these tools in their daily work. And in working with the PDSA model, we're going to pick one unit to do a pilot test of the tools. And we're going to, in this case, we're going to pilot test on one 10-bed hallway of one unit. Next, we're going to predict what will happen when the test is carried out. In this case, we want nursing assistants to utilize the tools and report changes in conditions to charge nurses who will further assess their patients for sepsis screening. And if our measures are prediction succeeds, the number of sepsis cases will decrease. Again, this is the P in the PDSA model. The next part, again, the D is do. We're going to describe what actually happened when we ran the test. The S is for study. We're going to describe the measure results and how they compare to our predictions. And A is act. We're going to describe what modifications to the plan will be made for the next cycle from what we learned with the first cycle. Again, through much teamwork and effort equals success. Again, features of successful healthcare organizations is they use data to track performance, they set goals and make them visible, they conduct root cause analysis, they use team to pilot test their ideas, or they pilot test for short periods of time with a few residents. They empower their staff to solve problems, they provide resources to staff to achieve the goals and solve problems, and they learn from others. However, you will have problems on the way, but obstacles can be overcome through teamwork. Often when we go to conferences or review a PDSA manual, we see a nice, straight improvement rate that gets better with each cycle as shown on this slide here. And it looks like it's all a nice, easy process. In reality, most projects look more like this. The line continues to go up over time, but you have many valleys and peaks and valleys. You will have some starts and restarts as you move through the cycle. As many of us have experienced firsthand as we've gone through this process, this is a more realistic picture of an improvement process. So again, don't get discouraged because many times we have to start and stop and correct things along the way. Again, maintain the game. Only through teamwork can we maintain the game. We don't want to get into the blame game as the cartoon illustrates. We don't want to say, before we begin to analyze what happened, just let me say it's not my fault. We don't want to point fingers. Again, it's only through teamwork that we can continue to make progress on this. You might observe that the PDSA cycles require data and ask where do we get all this data. We encourage everyone listening today to join the Advancing Excellence in Nursing Homes campaign. Advancing Excellence has a wealth of data collection tools and resources that are available to you. The majority of AE aligns nicely with the goals that we have in this project. Again, there are tools and resources, there are graphs and things that you can utilize within that. So rather than recreate the wheel, we can refer you to that as a resource, and you can also use their data reports when possible. If you do choose to join Advancing Excellence, please grant VHQC access to your data. This is a screenshot of the AE tools that are available to you. Again, we encourage you to use AE, but your organization may already have a software package or other tools for PI data collection. If you need assistance, we can help you. We can help you develop a simple spreadsheet for data collecting, or we can help you develop a manual tool with pen and paper if that's what you need. We want to make this work for your organization, and we'll work with you to find and develop tools that meet your needs. One of the benefits of participation, again, it's a flexible, no-cost structure for improvement. You'll get assistance with quality assurance, performance improvement, tools and resources. You'll hear the latest strategies and techniques from your successful colleagues and QI experts. You'll get intervention development ideas and assistance, and you'll also get support participation as you go into other QI initiatives. Our commitment to you is we'll prepare data reports and facilitate analysis. You'll see the bullets under bullet 1 there of the data that we will provide to each nursing home. And I want to take a minute and digress just here. You will receive a package from us in February which will have the data on these outlined bullets. And I want to make everyone aware that your data will not be shared with anyone. It's your data and for your use. We will not share your data with any regulatory agencies or other groups. It's, again, for your use only. If you make great strides and improvements, we may reach out to you and ask that you share your data, but it would only be shared after we ask you and we are granted permission to do so. So, again, your data is important and it's protected and it's only for you. Again, our commitment also is to provide consultation with our qualified staff and faculty, to share best practices and tools, to develop and facilitate collaboration using workshops and affinity groups, and provide expertise and practical assistance. So what are the next steps for you? You can sign up for the online VHQC Quality Innovation Network. Sign on to Advancing Excellence, that could give you a lot of resources and give us access to your data. Participate in the upcoming events posted on the online community and sent to you via email. And again, the slides, resources, and recording will be posted on that online community. Again, here's a screenshot of our online community, and again, we do encourage you to get connected to that as soon as possible. Our Sepsis website has been developed, and we will begin populating that site with resources and tools early next week, so you'll be able to access those tools in a timely manner. You can stay connected with us through website and Twitter. And at this time, we'll now open the lines for question and answer sessions. First, you'll post the evaluation. We'd ask you to do the evaluation, and then we'll open the lines for questions and answers. And thank you for being with us today.
Okay, certainly the floor is now open to your questions. If you have a question or comment, please press 7 on your telephone keypad. Okay, the first question comes from Orspas. Orspas, the floor is yours.
Yeah, I have a question. We are using Abacus. What is the difference between Advancing Excellence versus the Abacus?
Hello, this is Sheila McLean, and I'm the Program Director here at VHQC, and I'll be happy to actually take that question. Advancing Excellence is actually a national quality campaign, and they have various quality goals that facilities can choose to select as a quality improvement project, and then those various goals have associated tools and resources. And as David shared, many of those align with the work that we're doing here at VHQC, and in particular the infection work. But it's just out there as an alternate, as another source of tools and resources. So if you have a program such as Abacus that already provides you, tracking and trending tools and QI support for various projects, you don't have to use it. It's just we know some facilities may not have those type of electronic tools in place, and so we just wanted to offer some alternates. Does that help answer your question?
Yep. Thank you so much.
You're welcome.
Thank you. Again, as a reminder, for a question or comment, please press 7 on your telephone keypad. Okay, at this time, there are no further questions.
Again, we thank you for your participation today, and you'll be getting an email very soon about our next webinar, and I think it's February the 18th, but you'll get some details, and at that time we will go into much more details about the sepsis screening tools, the data package, and some information that we'll need from you guys on a fairly regular basis. Again, thank you, and we look forward to working with you on this project. Have a nice afternoon.
Thank you. This concludes today's teleconference. We appreciate your participation. You may now disconnect your line at this time.